Hello, everyone. We'll get started shortly. Hello, welcome to today's webinar, ASCO 2025, What's New for MBC? I'm Kate Fitzer, Share's Metastatic Program Director. Before the presentation begins, I'd like to tell you a little bit about Share. We're a national nonprofit that supports, educates, and empowers anyone diagnosed with breast or gynecological cancer and provides outreach to the general public about signs and symptoms. Because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, and our support lines, please visit our website at sharecancersupport.org. Now we have a few housekeeping reminders for all of you. All participants will be muted during the presentation. Once our speaker finishes presenting, we'll begin the Q&A discussion. Please submit any questions through the Q&A section at the bottom of your screen. And remember that the speaker cannot give specific medical advice, so please keep your questions general. Many questions are already submitted during registration, so thank you to everyone who submitted those questions. We also have closed captioning available. You can enable this feature by clicking the live transcript button at the bottom of the screen and selecting the subtitle option. Lastly, this webinar is being recorded, and in a few weeks, we'll share the recording with all registrants and add it to our website. Now, I'd like to hand it over to Dr. Schreier. The screen is yours.
Thank you so much. Hi, everyone. My name is Dr. Ashley Schreier. I am a breast medical oncologist at Weill Cornell, New York Presbyterian in New York City. I am excited to be here today to share some of the very exciting research updates that were presented at ASCO this year. So I'm going to share my screen. Can you see my slides okay?
Yes, perfect.
Thank you. Okay, so ASCO 2025, what's new for metastatic breast cancer? So there were a lot of really exciting studies that were presented for all different types of breast cancer, especially in the metastatic setting. I'm going to just highlight the three most impactful studies that were presented that I think really will be important in next steps in changing practice for breast oncologists and for our patients. So the first study is SERENA-6. This is a study that was looked at in metastatic hormone receptor positive breast cancer and involves switching therapy before progression based on circulating tumor DNA. So the study looked at camizestrant, which is a newer endocrine therapy medication, plus a CDK4/6 inhibitor for the treatment of emergent ESR1 mutations during first-line endocrine-based therapy and ahead of disease progression in patients with hormone receptor positive, HER2 negative advanced breast cancer. And this was a phase 3 double-blind study. So just some background, approximately 70% of breast cancers are hormone receptor positive, HER2 negative, and the estrogen receptor, or ER, is encoded by a gene called ESR1. And mutations in ESR1 can actually occur during the disease course and while patients are exposed to endocrine-based therapies. So ESR1 mutations are very rare, less than 5% upon diagnosis of metastatic breast cancer, but they can emerge in up to 40% of patients at the time of disease progression. So this drug called camizestrant is a next generation oral selective estrogen receptor degrader, as well as a complete ER antagonist. So it completely blocks the estrogen receptor and also degrades the estrogen receptor. So it's a novel type of medicine that's not currently on the market. And this is used, this has been tested in patients with mutant ESR1 as well as wild type, which means non-mutated ESR1. And on the right-hand side, you can see a diagram that just depicts the mechanism of action of this drug. So on the top, this is the membrane, the cell membrane of the cancer cell. So all the way at the top, you see testosterone. Testosterone is converted into estrogen in the peripheral blood by an enzyme called aromatase. So the pills that many of you may be familiar with, like letrozole, anastrozole, and exemestane, these are aromatase inhibitors. So they block the peripheral conversion of testosterone into estrogen. And estrogen comes into the cancer cell and then attaches to the estrogen receptor at the nucleus of the cell. And then that can change some of the genes based on the estrogen receptor's activation. So this drug, depicted in the little green shape on the right-hand side, you can see that camizestrant completely antagonizes, so completely blocks the estrogen receptor, and it also can degrade the estrogen receptor, and this blocks the pathway for cancer growth and progression. So this picture is just an overview that I thought was really important to highlight, because right now in practice we are using mainly we have a few drugs for blocking estrogen and its function, but there are so many different classes of drugs that are up and coming within the research world, and that are going to be approved soon and have been approved even within the past year. So we have basically 4 categories of estrogen receptor antagonists, which are receptor blockers. And then we have newer drugs that are being studied called PROTAC degraders, which break down the protein of the receptor. And so this slide is really just highlights, the excitement in the field with all of the new mechanisms that scientists have been discovering to further block the estrogen receptor, since it's such an important pathway of tumor growth and metastases in estrogen receptor positive breast cancer. So going back to the SERENA-6 study. So as I mentioned, the ESR1 mutations can emerge in about 40% of patients while they're on initial treatment with first-line therapy with endocrine therapy. Now, in recent times, we've been integrating the liquid biopsy into practice with something called ctDNA, which is circulating tumor DNA. And these liquid biopsies are currently done typically at some points throughout the disease course, and usually they're done in coordination with scans at the time of progression of disease. However, there has not yet been any guidelines or studies to show how we can use this liquid biopsy to change treatment. And that's why this study is so important, because that's exactly what the study looked at. So basically, we can detect these ESR1 mutations on this liquid biopsy, and that can be found before progression on an aromatase inhibitor and CDK4/6 inhibitor. So the first line standard of care for patients with metastatic estrogen receptor positive breast cancer is an AI plus a CDK4/6 inhibitor, and these mutations can be detected on liquid biopsy before a PET scan or a CAT scan can show that the drug stops working and that the disease is growing. And so we have 2 prior studies that sort of built up the rationale to do the SERENA-6 study. So one is the PATA-1 trial, which switched patients to fulvestrant, which is a selective estrogen receptor degrader with palbociclib upon detection of an ESR1 mutation ahead of disease progression. And then the SERENA-2 study showed that camizestrant significantly improved progression-free survival compared to fulvestrant in a pre-treated estrogen receptor positive metastatic breast cancer population. So again, SERENA-6 tested the hypothesis that using camizestrant to treat these emerging ESR1 mutations before CAT scans and PET scans can show progression of disease could extend the duration of benefit of first-line therapy. And so this is the schema of how the patients on the trial were randomized. So 3,325 patients were screened for the study. And again, they were on first-line treatment with an AI and a CDK4/6 inhibitor, and they had to have been on that treatment for at least 6 months. And then they were undergoing surveillance with liquid biopsies every 2 to 3 months. And then they were checking for this ESR1 mutation. When patients were found to have this mutation, they were then randomized to either this to continue the standard of care medicine, an AI plus a CDK4/6 inhibitor, or to switch to the study drug camizestrant with continuation of the CDK4/6 inhibitor. So this is the schema for randomization. So the camizestrant with the CDK4/6 inhibitor up at the top, and then in blue, continuation of standard of care was the second arm. And the main endpoint here was progression-free survival.
Progression-free survival is the length of time during and after the treatment of a disease, such as cancer, that a patient lives, but it does not get worse. Do you want me to keep reading?
So sorry, I don't know what that was. Some AI is listening to us. So, okay, Serena 6, statistical design. So the planned enrollment was 300 patients. And the primary analysis was planned after 195 PFS events. So this is just how they designed the study based on statistics. And so they basically had their primary endpoint of progression-free survival, and that was looked at the data cutoff of on November 28th, 2024. And if the study was found to show an improvement in progression-free survival, then they would move on to studying the additional endpoints, which will be presented in the future. So the baseline characteristics of the patient. So the median age was 61 on average, and this looks at the different characteristics in the two populations. So 61 in the camizestrant and CDK4/6 inhibitor arm, and 60.5 in the standard of care arm. So this chart basically shows that the baseline characteristics in terms of race, postmenopausal status, performance status, the presence of visceral metastases was pretty similar in the two groups. And then they looked at the timing of ESR1 detection. So on average, the ESR1 detection was found on liquid biopsy at around 22 months. So after 22 months of treatment, that was the average time that patients were found to have this ESR1 mutation develop. Again, it is a mutation that represents resistance to treatment, so it makes sense that it takes some time for it to kind of develop as the cancer is exposed to more treatment over time. And then the other thing that I thought was important on this table was that the time from initiation of the initial aromatase inhibitor and CDK4/6 inhibitor to randomization was on average of 23 months. So the primary endpoint of this study was progression-free survival, which was remarkably increased in the study arm compared to the standard of care arm. So patients that were switched to camizestrant and CDK4/6 inhibitor compared to those who continued on their first-line AI CDK4/6 inhibitor had an improvement in progression-free survival from 9.2 months to 16 months. So you can see the green curve is the camizestrant plus CDK4/6 inhibitor, and the blue curve is the standard of care. And then they looked at the outcomes based on all the different subgroups, just breaking it down by different characteristics of the patient, both demographically as well as clinically. And you can see here that the hazard ratio for progression-free survival was consistently improved with the camizestrant arm compared to the standard of care across all subgroups. And then there's another factor that they looked at, which is really important for patients in terms of quality of life and time to deterioration in global health status. Basically, this was also a marker that was very much improved with the study drug compared to the standard of care. And the reason that this is, very important, especially with these medicines is that the purpose of the study is to switch to a new medication earlier than we see progression on scans. And so the question is, of course, number one, is this beneficial in terms of survival? But number two, is it beneficial in terms of quality of life and side effects? Or do we wait until we see progression on a scan and then switch? And so showing that there's a reduction in the time to deterioration in health status and quality of life is really important when looking at these studies. And then they also looked at something called PFS2. So this data is not completely mature yet. We're still waiting for the final outcomes to be presented in the future, but it's very interesting that we do see an improvement thus far in PFS2, which means that this is the progression-free survival after the second treatment. So it basically takes into account patients that were not switched to camizestrant when the mutation came back positive. So patients that were in the control arm of the study that eventually switched over to camizestrant as a second-line therapy. And this is the safety summary. So the amount of adverse events or side effects were pretty similar between the two groups. And you can see that, the overall side effect profile is pretty low compared to other treatments such as chemotherapy. And you can see the differences. So the green are the side effects in the camizestrant arm, and the blue are the side effects in the standard of care arm. So the amount of side effects is pretty similar between the two groups. It seems like the camizestrant medicine may have some more neutropenia or low white blood cell count compared to the standard of care, but otherwise the side effect profile is pretty consistent. So in conclusion, switching from an aromatase inhibitor to camizestrant with continuation of CDK4/6 inhibitor, guided by the emergence of an ESR1 mutation during first-line treatment before CAT scans or PET scans show progression of disease, significantly improves the progression-free survival in patients with hormone receptor positive, HER2-negative advanced breast cancer. And this progression-free survival benefit was consistent across all subgroups that were studied. And camizestrant plus CDK4/6 inhibitor also delayed the time to deterioration in quality of life and improved and showed that it was well tolerated with a very low risk of discontinuation because of side effects. So again, this study was very groundbreaking because it was the first global registrational phase 3 study to demonstrate clinical utility of using liquid biopsy ctDNA in order to detect an emergent mutation and to change therapy based on those results. So this is very, very groundbreaking and very exciting data. And this study was published in the New England Journal of Medicine after the presentation. So now I'm going to shift gears. This is a study called ASCENT-4, which is in metastatic triple-negative breast cancer. And this is a study looking at combining an antibody-drug conjugate with pembrolizumab. So sacituzumab govitecan plus pembrolizumab versus chemotherapy plus pembrolizumab in patients with previously untreated PD-L1 positive metastatic triple-negative breast cancer. So for some background, there's an unmet need in previously untreated PD-L1 positive metastatic triple-negative breast cancer patients. About 40% of these patients who are diagnosed with metastatic triple-negative breast cancer have their tumors are positive for PD-L1, which is a marker of immunogenicity of the tumor. And so in these patients, in this 40% of the population, they are treated as standard of care currently with chemotherapy in combination with anti-PD-1, which is an immune checkpoint inhibitor. And that's in the first line setting. And that usually yields a progression-free survival of about 7.5 to 9.7 months. However, up to half of patients with metastatic triple-negative breast cancer actually do not receive second-line treatment because their disease becomes too aggressive. And so the rationale for this study is kind of utilizing two of our very effective medicines together up front rather than waiting to switch from one to the other at the time of progression. So SG, or sacituzumab govitecan, is the only TROP2 directed antibody drug conjugate with an overall survival benefit in multiple phase 3 studies, and it's approved currently in the second line for metastatic triple negative breast cancer. It's also approved in hormone receptor positive, HER2 negative metastatic breast cancer. So in these results, they're looking at using Pembro with SG versus chemo plus Pembro in previously untreated PD-L1 positive metastatic triple negative breast cancer. So just an overview again of the current challenge in metastatic triple negative breast cancer. So the current first line for patients with PD-L1 positive tumors is to get pembrolizumab in combination with chemotherapy, and that yields a 9.7 median PFS and an overall survival of 23 months. So the schema shows the randomization of these patients. And so the patients had to be PD-L1 positive before being randomized, and they had to have at least a 6-month interval from treatment in the curative setting. So the patients were randomized to SG plus Pembro versus Pembro plus chemotherapy, which is the current standard of care. And the demographics and baseline characteristics were pretty similar between the control group and the study group. What's important here to look at is on the bottom left, we see de novo versus recurrent disease. So 34% of patients in each arm had de novo metastatic disease, meaning that they were diagnosed with metastatic disease at the time of their breast cancer diagnosis, versus the other 2/3 of patients who were initially stage 1, 2, or 3, had received curative intent treatment and then recurred with metastatic breast cancer, which is the majority of the cases that we see with metastatic breast cancer are patients who have previously had an early stage breast cancer. So out of these patients, most of them had a recurrence that was over 12 months ago, and about 18% in each arm had a recurrence that was recent, within 6 to 12 months. So this is the progression-free survival. So there's a difference if you look at the top right. There's a difference in the SG Pembro arm. The PFS was 11.2 months versus 7.8 months in the chemo plus Pembro arm. And you can see the dramatic separation of the curves here, the blue being the SG Pembro and the red being the chemo Pembro. So SG Pembro demonstrated a statistically significant and clinically meaningful improvement in PFS versus chemo Pembro with a 35% reduction in risk of progression or death. And with subgroup analysis, this combination showed improvement essentially across all subgroups. There's 1 or 2 that were close to the line, so you can see on the dots are basically representing the mean, and on the left-hand side, on the left-hand side of the dashed line, that means that SG Pembro was better or was favored and had a better PFS. So there's one group that's interesting that where the dot is on the other side of the line, meaning that chemo and Pembro was better. And this was in the patients that had not previously the patients that had previously received pembrolizumab in the neoadjuvant or adjuvant setting for early stage breast cancer. However, this should be interpreted with a grain of salt because there's only 9 patients in this subgroup, and so it's really too small to get any sort of statistically significant information out of that. However, it is interesting to note that only 5% of patients in this study received pembrolizumab in the neoadjuvant or adjuvant setting, which is not exactly what we're seeing in practice today, where in current clinical practice, most of the patients would have received that in the prior curative setting in the neoadjuvant or adjuvant setting. Okay, so the overall survival is not ready yet. It's still immature, so we'll have that hopefully in the future in a couple of years. But thus far, there seems to be a trend towards improvement in overall survival with SG Pembro compared to chemo Pembro. This slide is showing the tumor responses and duration of response. So on the left-hand side, there were 28 complete responses in SG Pembro compared to 18 complete responses in chemo Pembro. And then on the right-hand side, you can see the survival curves for duration of response. So in the blue, SG Pembro had a higher median duration of response of 16.5 months compared to 9.2 months in the chemo Pembro arm. So there was a substantially longer duration of response and a higher overall response rate observed in SG Pembro compared to chemo Pembro. And this is looking at adverse events. So we are, using SG and Pembro currently in clinical practice, and there were no new adverse events or side effects that were seen in this study. And despite the longer duration of treatment with SG Pembro, the rates of grade 3 adverse events were similar for both groups. And the amount of side effects that led to reductions in dose or discontinuations of treatment were actually lower in the SG Pembro group. And this kind of breaks down the side effects by the different drugs. And again, they were consistent with the known toxicity profiles of these drugs. So conclusions for the ASCENT-04, this is the first randomized phase 3 trial to evaluate the efficacy and safety of an antibody drug conjugate with a checkpoint inhibitor in the first-line treatment for patients with metastatic TNBC whose tumors are PD-L1 positive. This combination led to a remarkable improvement in progression-free survival of 11.2 versus 7.8 months. And the overall survival data looks like it is going to be impressive. However, it's still immature at this time. We also saw an improvement in overall objective response rate as well as duration of response. And so these results support the use of SG Pembro as a potential new standard of care in previously untreated patients with PD-L1 positive metastatic triple-negative breast cancer. And this study shows that there may be potential for earlier utilization of SG, which is currently used in the second or third line setting. And we need to think about ways of putting this into context of patients that have already received pembrolizumab in the neoadjuvant setting, which is something that's becoming more frequent. And the study also looks at recurrent disease versus de novo metastatic breast cancer and how we saw those two subgroups that both of them did benefit from this treatment, but it will be important to think about those two populations and how they may respond differently to the combination. And then, of course, research is needed to demonstrate the safety and efficacy of sequencing antibody drug conjugates. And so these are newer drugs that have been coming into clinical practice, into the treatment paradigm for our patients within the recent years. And sequencing them is something that we need to study more and learn more about which order to give these medications. And then, of course, we await overall survival data from this study. So the last study that I'll be talking about today is the Destiny Breast 09. So this study looked at trastuzumab deruxtecan or Enhertu with pertuzumab compared to taxane chemotherapy with trastuzumab and pertuzumab for first-line treatment of patients with HER2-positive advanced metastatic breast cancer. So there's been an evolution of T-DXd or Enhertu in advanced HER2-positive breast cancer. Basically, when T-DXd was introduced in the Destiny Breast 01 phase 2 trial, it showed a remarkable progression-free survival of 16.4 months. It was used in the third line or beyond, and then subsequent studies introduced T-DXd into the second line, which had an impressive progression-free survival of 17.8 months. And as you can see, this progression-free survival surpasses the standard of care in every study that it's been tested. So it improved ahead of chemotherapy and then improved ahead of T-DM1 for second-line treatment in the Destiny Breast 03. And so basically the trend here, like with any new drug that's introduced, it started, getting tested in later lines of therapy and then eventually moves its way up into the front line when it's shown to be very effective, as is T-DXd. And so this study is moving T-DXd up to the front line with the addition of pertuzumab or Perjeta. And this is being compared to the current regimen of a taxane plus Herceptin Perjeta, which is the current standard of care based on data from a study called Cleopatra. So the rationale for this, basically, if you look on the left-hand side, there is a diagram of the HER2 receptor at the surface of the cancer cell, and there are two sites where the drugs are essentially targeting. So on the left-hand side in the orange, you have pertuzumab or Perjeta, which is attaching itself to one part of the HER2 protein, and then T-DXd is attaching itself to the other side of the protein. So essentially the drug combination is showing that you're kind of hitting the receptor from two separate targets, and they're working in two separate ways. And so the pertuzumab is blocking the receptor, and the T-DXd is also blocking that receptor, but that receptor antibody complex gets internalized by the cell and releases the drug directly into the cell. And so you kind of have this two-pronged mechanism, which is why drug combinations are really, really interesting and can be very effective. So in terms of the randomization, so this study looked at, again, patients with HER2 positive advanced metastatic breast cancer that had a disease-free interval from prior early stage breast cancer of at least 6 months. And they had to have no prior systemic treatment for metastatic breast cancer. They may have had one line of endocrine therapy before being into the randomized in the trial. And the group stratified by 3 separate categories. Some of this data is still immature, but they were looking at de novo versus recurrent metastatic breast cancer, hormone receptor positive versus negative, as well as patients with mutated versus wild type PIK3CA mutations. So there were 3 study groups: T-DXd plus placebo, T-DXd plus pertuzumab, and THP. So again, THP is the current standard of care. The T-DXd and placebo is not currently available. That arm is still ongoing. So the data that was presented at ASCO this year is just for the THP versus the T-DXd plus pertuzumab. And the primary endpoint was progression-free survival, with secondary endpoints listed here, mainly including overall survival. And so, again, there were just 2 arms that were looked at in the data that was presented at ASCO this year. This is more about the statistics, which we pretty much already reviewed on the previous slide. And patient disposition, so 1,703 patients were randomized. Again, they were randomized 1:1:1. And so in the groups presented here, there were 380 patients in the T-DXd plus pertuzumab arm and 383 patients in the Taxol Herceptin Perjeta arm. And at the data cutoff analysis time, that was for the study data that was presented here, 39.6% of patients remained on any treatment, and 45.8% of patients had the T-DXd plus Perjeta, compared to 33% of patients in the THP arm. So the median duration of follow-up was about 30 months. So patient demographics and key baseline characteristics. So on the left-hand side, you see the T-DXd and Perjeta arm. On the right-hand side, we see the THP. And so interestingly, when looking at hormone receptor status, about half, or a little over half, 54% of patients in each arm were hormone receptor positive. And likewise, about half of patients in each arm had de novo metastatic disease. And then they also looked at the mutation status in terms of PIK3CA mutations. They were interested as well in patients with brain metastases and those with visceral organ metastases. And this table looks at the prior therapies that patients received. And so the characteristics between the 2 groups was pretty similar. And progression-free survival, the primary endpoint, was substantially increased in the T-DXd pertuzumab arm compared to the standard of care THP. So there was a progression-free survival of 40.7 months compared to 26.9 months. So there was a change. There was a delta of 13.8 months, which is really, really incredible. This is another look at the progression-free survival using a different statistical analysis, and it was also quite remarkable. So looking at subgroups, again, you can see across all subgroups, the treatment arm with T-DXd pertuzumab was, beneficial across the board in the three categories that the investigators were most interested in, as well as demographic data and demographic characteristics. And this figure is looking at objective response rate, and it showed that if you look on the left-hand side in blue, we can see 85% of patients had, there was an 85.1% objective response rate in the T-DXd pertuzumab arm compared to 78.6% in the THP arm. And what was also interesting here in the darker blue is that 15% of patients in the T-DXd pertuzumab arm actually had a complete response compared to 8% in the THP arm. So the responses were greater, and they were also durable. So on the right-hand side, you could see the duration of response. That's the DOR. And you can see it with T-DXd pertuzumab, it's 39.2%. Versus 39.2 months versus 26.4 months. And the overall survival here is also immature, but it's definitely trending in a positive direction, showing that it's favoring T-DXd pertuzumab versus THP. And the overall safety summary is pretty similar between the two groups, and also pretty similar to what is already known about these two drugs, which are both currently used in standard of care. And again, toxicity profiles were consistent with what is known. The one important thing to note here is that the T-DXd plus pertuzumab is more toxic compared to the THP. So the blue lines you can see are a little bit longer than the gray lines on the right. And so there is more nausea with this regimen, some more blood count abnormalities. There's a potential for more hair loss compared to THP, because typically in the current standard of care, we're using Taxol, Herceptin, Perjeta for a few cycles, and then eventually the Taxol chemotherapy is dropped, and patients are maintained on anti-HER2 therapy alone, which is very, very well tolerated. So, with these amazing results, we always need to think about quality of life and side effects, and whether it makes sense to use, all of these drugs at first, or to kind of stagger them one after the other, which is what has been in, clinical practice currently. So it's definitely very interesting, and I think will kind of depend patient to patient on how we're going to approach this. So again, the adverse events of special interest were mainly the ILD, the interstitial lung disease, and pneumonitis, which is present with Enhertu or T-DXd, which is well known. The rates of ILD pneumonitis were consistent with what has been seen in other T-DXd trials. And then also left ventricular dysfunction is another important side effect with the use of any HER2-directed therapy. So in conclusion, T-DXd plus Perjeta demonstrated a statistically significant and clinically meaningful benefit in progression-free survival. And this was consistent amongst between all subgroups. There was a hazard ratio of 0.56. The median progression-free survival was 40.7 months compared to 26.9 months, with a duration of response greater than 3 years, and a complete response rate of 15%. So early overall survival data is suggesting a positive trend to favoring T-DXd plus pertuzumab, and the T-DXd pertuzumab safety data was consistent with known profiles of individual treatments. And so there, in addition to the remarkable progression-free survival benefit, there was a 44% reduction in risk of disease progression or death with T-DXd and Perjeta versus THP. So again, this is a potential new first-line standard of care for patients with metastatic HER2-positive breast cancer, which is very, very exciting. Okay, so those are the 3 studies that I wanted to highlight, and I thank everyone so much for your attention, and I'm happy to answer any questions that come through. Thank you.
So now let's start the Q&A. You can still submit your questions in the Q&A section at the bottom of the screen. We'll try to get to as many questions as we can in the remaining time. Dr. Schreier, thank you for walking us through the important study, the ASCENT-4. A question that came up from a few patients regarding Trodelvy and Keytruda. They're both FDA approved, and they are wondering how soon could these options, the combination of sacituzumab and pembrolizumab, realistically become part of the care outside of the clinical trials?
That's a great question. This data is very compelling, and I think a lot of clinicians are starting to use the combination in certain cases, and unfortunately, the combination is not yet FDA approved, and so logistically, just getting insurance approval and stuff is kind of dependent on different factors with insurance companies. But I think the New England Journal paper was published after this presentation, and so I think hopefully in the near future we'll have an FDA approval with this combination, and then it will be more widely accessible.
But you are seeing people are having the combination already with outside of the clinical trial?
So I haven't yet seen it personally,
Oh, okay.
but at the ASCO meeting, some doctors had used it already that have had success with it. So I just haven't had an opportunity yet to use the combination, but I definitely would try to get it approved if I was able to.
So I want to switch to the next question. Comes from about Destiny Breast 09, especially concerning. Some patients are about moving the antibody drug conjugates earlier in treatment. One patient wrote in and talked about the toxicity, considering if the toxicity when compared to the standard of care, if these newer drugs like Enhertu show strong results early in treatment, how are doctors going to decide and when are they going to use them in the future?
Yeah, that's a really, really important question that we're all talking about now after these presentations. And so, I think it really depends on the patient. And, in my practice, we kind of make these decisions together, and it depends on side effects, the patient's other medical problems, what kind of, what they value in terms of toxicity and quality of life. Also it depends on the age of the patient. So in someone that's elderly with a lot of medical problems, I think it's very appropriate to, continue with the current standard of care, because it is so well tolerated. But in a younger patient, let's say without any other medical problems, they might be interested in a little bit of a more kind of aggressive regimen up front. So I think it's, like any other treatment nowadays, we have kind of this good problem where we have so many options, right? And the question is how to sequence these options, when to use which one, and which one should we use first. And I think that's something that we're still all adapting to. But again, it's a good problem to have. And we, like any of the other combinations or new drugs that come into play, we kind of have to make individualized decisions based on the patient, the medical, medical problems of the patient, the age, as well as the patient's values and what the doctor advises. So it's a nuanced decision that's very individualized.
Mm. Yeah, that's so true. Okay. So we're going to move on to the Serena 6 trial. The promising new targeted treatments that you talked about, camizestrant. Um, the next question is for patients currently on hormone therapy or facing resistance, how might camizestrant fit into the treatment plans in the near future? And what should patients be asking their doctors?
Yeah, that's a great question. So I think it's a matter of time before camizestrant will get approved. And so I think that, it's something that's certainly on the horizon. I think patients can ask their doctors, about circulating tumor DNA and the liquid biopsy, which many doctors are doing routinely at, different frequencies. But identifying, this resistance mutation is helpful to know about for the doctor and the patient. Whether or not we're going to use it at this moment to switch therapy, I think that will depend on the FDA approval once we have some more data, but also may be also something that is just helpful to know about when deciding when to get scans for a patient. And so I do think it's a matter of time before we're going to kind of see this come to fruition in practice.
So another question related to that is, should everyone with HR positive MBC be tested for the ESR1 mutation, even if they're not showing progression?
Well, it is important to be tested for this mutation because we do have another drug called elacestrant that targets this mutation. But you're right, we mainly check for it at the time of progression. So if a patient is not showing progression, currently it's not in any sort of guideline that we should check for the ESR1 mutation because it's not necessarily going to change our treatment in this moment. But again, it is something that I think could be done, if that's something that's important to the patient to kind of know about that in advance. It may lead us to getting a scan earlier than we normally would. And so that's something that is, it is something that's important and that I think really should be considered for all of our patients.
Mm-hmm. So now the next question is a general question about clinical trial access. All these trials, there's like growing excitement with all the new trials and new discoveries and new treatments that are possible. But there's also a concern on the patient end as far as like access. How can patients find out if they're eligible for one of these trials, and what are the first steps for them?
Yeah, so the first step is to talk to your doctor. Every medical oncologist should be able to have access to a database of available clinical trials and assess whether or not you may be eligible. And, whether or not your practice has the clinical trial on site or if they're at a neighboring site, that's something that becomes a challenge depending on where you live and where you're getting your care. However, there are more and more trials coming into community practices. And I think the other thing that is helpful for patients, if you are interested in exploring, is clinicaltrials.gov, which is open to the public. And so that you can kind of type in any keywords to search for trials that way. But also, with the guidance of your physician who will be able to access that and guide you.
So if a patient does look through clinicaltrials.gov and they find something that might be interested, but it's not at their community center, what advice would you give to them, or they haven't heard from their oncologist about it?
They could, I would recommend, looking at the closest geographic site that has it available to where you're located, and you can email that investigator. Their contact information is usually posted on the website, or you can call that cancer center to get, even a second opinion appointment to see if you would be eligible.
What would be a few key takeaways for patients from the presentation and what you heard at ASCO?
So I think like the 3 studies that I presented and some of the other studies as well had a very similar theme in terms of just kind of bringing these newer drugs up to the first line treatment for metastatic disease, and also combining things sooner. So the current, the traditional way of treating metastatic breast cancer is using one drug at a time in sequence. And once a patient progresses on one drug, we move to the next, and then we move to the next. And unlike in early stage disease, when we're trying to eradicate the cancer and cure it, and we're giving 4 or 5 drugs at once with a brutal toxicity profile in metastatic disease, the thought is to use one drug at a time. That's more tolerable and gives us, better quality of life, since the drug is going to be used over more of a long term. But in recent years, and even in just these recent, presentations, more drugs are being used upfront and in combination that we really haven't seen before in metastatic disease. And part of the reason is because we have all of these really amazing drugs, but also metastatic breast cancer in some ways is being treated more like a chronic illness, since we have so many drugs now that are available to us, and we're seeing survival rates that are surpassing, anything that we have seen in the past. And so, that being said, we're kind of really, in certain ways, some of these studies are looking at more aggressive combinations, if you will, up front to kind of just give us this longer window of progression-free survival. And so I think that's been the theme of the recent presentations, and I think it is very exciting. Of course, should be, interpreted and applied in a patient-centered, individualized manner, because that approach may not fit for every single patient. But I think that's been pretty much the theme here. But it's very exciting to be having all of these new drugs kind of coming out in real time for us.
So before we close, we have one final question that many patients are wondering about. With all these new trials and emerging treatments, what advice would you give to someone trying to stay hopeful while navigating all these options and the uncertainty that comes with metastatic breast cancer?
Of course, yeah. This is a big topic that I talk about with my patients a lot. And, I kind of like to emphasize the fact that we are sort of treating this more like a chronic illness nowadays with the new drugs that we have. And so I think it's important, to remain hopeful, just given the fact that we're seeing these new drugs and new combinations, coming out before our eyes. And even in the past year, we've had, more than one new drug getting approved by the FDA for metastatic breast cancer. And so I think navigating this is challenging, but it's also exciting. And, talking with your doctor and exploring the options, thinking about all of the, combinations that are available and the newer drugs that are available, and just reviewing the different options with your doctor should help to kind of ease some of that uncertainty. But also, it should, provide us with more hope, in treating these diseases, because we're seeing just more and more research every day to kind of bring better survival outcomes and better overall outcomes for our patients.
Thank you so much, Dr. Schreier, for your thoughtful and thorough answers to all these questions, and for providing us with this wonderful presentation today. Thank you, everyone who joined us today. We will have a recording of this program available on our website in a few weeks. Please check Schreier's website for upcoming educational programs and support groups. And don't forget to follow us on social media as well. Please take a moment to complete the survey at the end of the webinar. The survey will pop up in the browser when the webinar ends, and the link will also be in the follow-up email. All surveys are anonymous. This concludes the webinar. Thank you again, Dr. Schreier, and I hope everyone has a great day.
Thank you so much, everyone.